Now they're ready and care, patient is on table. We'll go live to care and we can have any discussion during the sessions. We'll have a renal denervation and on structural heart case coming up. Yeah, Dr. Nrasimhan?
Yes, good afternoon. From Care Cath Lab, we have Dr. Lawrence and Dr. Anuj joining me in this procedure. And we have our Cath Lab team with our techs. We have done one side, the renal denervation, and we are going to demonstrate on the other side.
Doctor, one minute, Dr. Nrasimhan, we have Dr. Venkatesh Ram with us here along with Dr. Manjunath and Dr. Satyamurthy. Dr. Radhakrishnan is there to take up for other session. They will be interacting with you. Right. Thank you.
Can you give the patient's history?
Morning, everybody. This is a 58 who's hypertensive for the last 20 years and been on 6 antihypertensives, including he's a 58-year-old gentleman, been a hypertensive for the last 20 years. And he's on 6 antihypertensives and his baseline pressure is around 170, 90, 170, 100. His antihypertensives include diuretic, beta blockers, adequate doses of ACE inhibitors, and Minipres XL, Arginine, as well as he's a doctor himself and he's opted for the procedure himself actually once we explained it to him.
Go ahead. Opening pressure was 190. Go ahead. Lawrence.
So if
opening pressure was 190 by 100. We have cannulated the left renal with a renal guiding.
Can you show the fluoro image, please?
Can you show the fluoro image, please? Here. Are you able to see the fluoro image?
We are able to see it now. Go ahead.
Okay. You see in the other screen, that is the scout angiogram. First we have taken to see where there is a distal bifurcation of the polar arteries. We are starting the lesion just proximal to that.
Dr. Nrasimhan, can you just show the renal artery pictures?
Can you run this renal artery here? Scene minus.
Okay.
Before the catheter is put in.
The ostium is all right. We have taken that's the renal artery. We have just put a marker on the fluoro screen to show where there is a distal bifurcation of the renal arteries. So we want to start the lesion, delivery of the lesion at the distalmost site where the vessels are going to bifurcate. Can you fluoro now? Yeah. So the catheter is deflected, as you can see, the catheter is deflected, which is going to touch the inferior surface of the renal artery now. We are first delivering the lesion on the inferior pole of the renal artery. Can you focus on this? The starting impedance is 210. Can you go on the pedal, please?
Show the RF generator, please.
Show the RF generator. 210 is the impedance on the first column, which is fluctuating. Can you go on RF? As the RF is being delivered, you can see the impedance is dropping from 220 to 214, 215. Make it 10 watts.
So what is the sedation protocol, Dr. Nrasimhan? Because
this patient has received, I'll ask Abhijit to tell you the details. He has received 2 milligrams. Go ahead.
We have given him 100 mics of fentanyl. He's 105
because they have to be really adequately sedated because it causes a lot of severe abdominal pain at the time of delivering the energy.
100 mics of fentanyl, 2 milligrams of midazolam and a fentanyl and a propofol drip is going. Can see this is the sufficient drop in impedance. From 220 it has dropped to around 210 now, and we have titrated the power to achieve this. We started with 8 watts, we have stepped it up to 10 watts now. Go to 12.
You are going from distal to proximal, right?
That's right, that's right. Okay. Each area we deliver 90 seconds to 120 seconds of RF.
Okay. Now you can switch over to fluoro. Yeah.
go off.
Essentially,
Release the deflection.
you decide the distal marker where you
Yes,
need
the
not go beyond the
deflection.
bifurcation.
You can
Be
see the
cautious
deflection
about
is being
it.
released, and then he is going to torque the catheter clockwise, which
Can
will
show-
take it to the posterior pole. Torque it. He is torquing the catheter now.
Can you make picture in picture, show his hands in a
Show
small
the
picture
hands.
and have a fluoro?
Yeah. So this is the second spot, which is going to be on the posterior wall of the renal artery at a different point. We're going to start the second section here. Impedance is 218. Can you go to the impedance, please? Start the RF, please.
I got a question for Dr. Venkatram. After renal denervation, will the ARBs act if you give them?
No, it should not have any effect because there is no major renal hemodynamic effect other than the renal resistive index goes down a little bit. But otherwise, the RAS manipulation
15.
after denervation should not have any impact.
So I have got a question to Dr. Ram as well as Dr. Nrasimhan. Can you predict the outcome by any biochemical or other means?
The question was, can we predict a response? Actually you can't predict at the time of the procedure, and the response is so variable, you just have to wait for the passage of time. In fact,
Come down.
the immediate response
8 watts.
may or may not happen at all. And you have to follow the patient, and there is incremental fall in blood pressure because of the renal denervation. It's not like renal angioplasty or stent where he has shown you'll see an immediate effect. This could be sometimes no effect at all. It's no way to predict.
And so one question to Dr. Satyamurthy, which I missed because of lack of time. We talk so much about BMS and DES in coronaries, but you don't mention anything about the nature of stent in renal angioplasty. Why is it so? Why don't we mention at all about drug-eluting stent or bare metal stent while doing renal angioplasty? Isn't there any difference between this? There is so much fight among the in the
because
coronaries, but we don't at all mention this issue while doing renal angioplasty. Why is it so?
The DS is not available in our country, and we have not used. So, and second thing, we are getting very good results with BMS itself. And the size of the vessels are 6, 7 and 8. So the restenosis rates are very less, unless you dissect the vessel.
I think somewhere Johnson & Johnson has come out with some drug-eluting stent for the peripheral angioplasty. So, there are some instances where suppose there is instant restenosis of the renal artery with a bare metal stent, you can use these peripheral drug-eluting stents.
Narasimhan?
Yes.
Dr. Radhakrishnan here.
Yes.
Tell me, how do you ensure proper positioning while you are manipulating the RF catheter? You have anything to guide you by, like angiography during the manipulations?
There are two things that you look at. If the catheter is in contact with the tissue, the impedance will not widely fluctuate. If you are in the space, in the lumen, and with respiratory variation it's changing, and the contact is intermittent, you will find that the impedance will keep on varying. So all that we do is take the distal side, put a marker there. I don't know whether you can see, there is a marker that has been pasted on the fluoro screen so that we know where it is, and then we have the idea where the ostium is, and we deliver lesions in between, guided by the impedance.
The second question is, how did you take the RF catheter into the renal artery? Did you take it through a guiding catheter or?
Yes, we have a renal guiding, and it's gone through a guiding.
And the third question is, you just mentioned that you torqued it so that it faces the posterior wall. How do you ensure that it is in the posterior wall?
That's what, once you torque for a left-sided curve, it touches the posterior wall and you can fluoroscopically validate it. The second thing is again the impedance. If you are not touching the wall, the impedance will change.
Okay.
Dr. Nrasimhan, this is a RF catheter or a simplicity catheter? What
This
is
is a regular RF catheter.
Okay, okay. Because in the regular, I mean, the simplicity catheter, there's a deflection, so you can
This
nicely
also can be
Even this also
deflected.
can be deflected.
This
Yeah.
can be deflected.
This is 4 French or what?
5.
The catheter is 4 millimeter tip,
Yeah.
but it's a 6 French catheter.
Okay.
Come to the osteo.
Can you show the hemodynamics of the patient once, and then probably if you have
we are
anything
guiding
particular to
the-
show, then
Yeah.
we can switch over to other lab. Can you show?
Opening pressure was 190. Now what you're getting is the guiding pressure, but the catheter is in the lumen, so you can't see the pressure very well now.
Okay.
Okay, deliver in the.
Dr. Nrasimhan, this is Dr. Soumitra Rai.
Yes.
As you were mentioning to touch the posterior wall of the renal artery, I think along the length of the renal artery, you are touching the different portions of it, posterior, anterior, superior, and inferior in turn.
Yes,
You are taking it in a spiral fashion, isn't it?
that's right. So that you don't deliver circumferentially in the same plane. You deliver it at different planes.
Yeah.
Go ahead.
Because the sympathetic chains are in circles and in longitudinal, so you have to
Yes.
break it at different points.
Is there any way we can assess whether the denervation has been complete or incomplete or partial?
I think sometimes what they do renal vein catecholamines level. Do a renal vein, biochemically to strongly document whether an effective sympathetic denervation has been done or not. People have done renal vein samples for catecholamines before the procedure, then soon after the procedure, then maybe 6 hours and maybe a month later. So this is how they have assessed the effectiveness of sympathetic denervation.
Yeah, that's possible. The only difficulty with the renal vein measurement of catecholamines is even with a normal, completely normal renal artery, the catecholamine release is very episodic, and it's not that predictable. More than that, I think the microneurography, which is only research tool, that is a much more reliable predictor of response, microneurography, where you can actually see the neural bursts go down with passage of time. Right. No, it's microneurography. It's like an EMG. It's ENG.
Yeah, basically, just for the sake of everybody, the monitors which are showing basically are showing the parameters which you can adjust the wattage, you can adjust the time duration in which it can be delivered, and whenever you have a loss of contact, the impedance changes. That's how we decide. All this needs to be particularly monitored whenever you are doing with this system, unlike RD and Medtronic system which has inbuilt mechanisms to auto cut off if there is a change, but you need to be a little careful. Here also it gets cut off, but you need to fix it ourselves. It's not everything is done. I think Nrasimhan, you want to tell anything else? So otherwise we'll move on to the next lab.
Yeah, for people who are beginning this, just look at the impedance starting impedance.
Yeah.
The moment the impedance goes above the starting level of impedance, that means you are forming a coagulum at the tip. So you need to come off immediately.
Yeah.
If there is an abrupt drop by more than 20 ohms, that means you are probably giving too much power than required. So you may have to titrate the power. If you are giving 12, make it as 10 or 8, go down on the power. So on an average about 15 to 20 ohms drop in impedance is what is desirable.
How many sites to be ablated each side?
Anywhere from 4 to 6. Basically we have just extrapolated from the simplicity data. 4 to 6 lesions circumferentially around in each renal artery.
Okay, any questions in the hall? Otherwise we'll move on to the other lab.
Nrasimhan, actually they say the sympathetic nerve ending density is said to be maximum at the ostium of the renal artery.
That's right.
So probably we have to do a couple of more ablations at the ostial level.
Yeah, the thing is there is something called as an anterior aortic ganglion. So when you come to the ostium, we try to make sure that it is facing the anterior wall. For a left-sided artery, we try to counterclockwise. You can see this, we counterclockwise and come to the anterior wall.
Okay.
and remain in contact with the ostium at the anterior wall and then deliver the lesion.
Fine, yeah.
Okay, go.
Is an already renal stent in situ a contraindication for renal denervation? Stent in situ in renal artery? Not known.
No, you are talking about patient has renal artery stenosis. Yeah, the only issue is if it is refractory. Yes, yeah. Then it has to be treated like a native renal artery.
Go up on the wattage.
Yeah. Yes. Well, stent anyway. You are not going. You are going to. We would have stented only ostial, but it should theoretically behave like a native renal
How
artery.
much the wattage?
But you can't deliver it through the stent with the same frequency. You cannot. You cannot, yeah. No, so far, now 36 months, probably 42 months follow-up with imaging, no renal artery stenosis as a result of procedure has been noted.
Only thing is, if the energy that you are delivering is not properly controlled, there can be really perforations.
We've shown the, can you go back, show the right side of the renal artery?
Dr. Nrasimhan, we are just discussing
Yes.
what is the energy that normally we use for RF ablation for your AVNRT versus this one. It is 1/4 of it or what?
Yes, we generally deliver about 30 to 35 watts. But remember, in a renal artery, when there is very high blood flow, there is cooling of the tip of the catheter. So the amount of energy that you require is much less. And generally we start with 8 to 10 watts. That's the final result on the other side. Aspirate flush and engage.
Yeah.
You can go to the other side.
Yeah, Dr. Nrasimhan,
Yes.
we are told the second lab is ready for the next live case,
Yes.
and we will leave you at this stage.
Sure,
and
thank
probably
you.
we will listen to your results later. Thank you very much.
Dr. Nageshwar Rao. Dr.
Hello,
Nageshwar Rao, are you
Kumar.
able to hear us? You are live. Dr. Radhakishan is with you. Please go ahead.
Hello, Srinivas Kumar, can you hear us?
Yeah. Dr. Radhakishan
Yes.
sir is moderating this side.
Hello, good morning, sir.
Morning.
We have team members here, Dr. Karnakar, Dr. Sudeep, and Vijaya's sister, Mr. Devender, and Dr. Samita, anesthesiologist here. We have a case scenario to talk a 12 years old girl who weighs around 36 kilograms. I request Dr. Karnakar to go ahead and present the
Good afternoon, sir, and warm welcome. This is a 12-year-old girl with weight of 36 kgs, with history of recurrent LRTS and dyspnea class 2 symptoms. On examination, she has systolic thrill in the parasternal area and pansystolic murmur. You can see the chest X-ray, it's showing cardiomegaly, an increased vascularity, and the ECG suggestive of normal sinus rhythm with LV forces. And 2D echo shortly will show you the images. It's a moderate 6 mm perimembranous VSD with septal aneurysm and moderate LV to RA indirect Gerbert shunt, and the mildly dilated LA-LV with LV IDD dimensions of 43 mm, Z-score of 1.8, and LA-iota ratio is 1.3. And our intended position is VSD device closure, retrograde technique. And the hardwares we used here is 6 French thermovalve sheath, arterial side, and 5 French venous side, and 6 French launcher catheter, and 035 J-tip thermowire, a VSD cable, and ADO2 ductal device.
Do you have the hemodynamic data with you?
Yes, we have hemodynamic data. We run the oximetry sample. Oximetry sample yet to come, but PA saturation, they said it is more than 75%. Absolute values, we need to calculate that. Whereas systemic pressures are 110 millimeters of mercury systolic, whereas the PA pressures, which is around 20 by 8 millimeters. So we don't have pulmonary hypertension. but the QPQS is apparently going to be high because we have clinically evaluated, there is a cardiomegaly, there is LV forces are high, and LV IDD G value is more than 1.88. The hemodynamic data is awaited, and we will just tell you at the end of the procedure. Sudeep, can you please show the echocardiogram?
So what's your measurement of the VST size on the echo?
The VST measuring 6.5 millimeter from the LV side.
Sorry, what's the size?
6.5 millimeter from the LV side.
I'm sorry, Nagesh, your voice is not very clear. What is the size of the VST from the LV side?
It is 6.5 millimeter.
6.5. Okay.
6.5 millimeter from the LV side, but the aneurysm alone measures around 9 millimeters, aneurysmal tissue, whereas internal tract which measures around 5.5 millimeters.
And on the RV side, that is distal to the aneurysm?
Yes, that is, there is an aneurysmal tissue, membranoseptal aneurysmal tissue. The jet is splitting into VST jet and indirect LV to RA shunt. So you have a shunt to RA as well as shunt to RV here. So since it's a moderate membranous VST, you can see the aortic wall to membranous VST distance is somewhat good, which measured around 5 to 6 millimeters. And our intended procedure is to use a 6 millimeter device here, since the narrowest diameter measures around 5.5 millimeter.
Is it a single jet or are they multiple?
It is single jet. The jet is seen from LV to RV directly. From there it is splitting into tricuspid regurgitation through the membranoseptal aneurysm there.
So is there no shunt from the LV to RV?
There is a shunt from LV to RV. There is a VST shunt. Can you show the LV to RV shunt? Echo, can you show the picture? There is a shunt.
Okay.
Part of the VST jet is directed to the right atrium.
So you are going to choose a 6 millimeter ADO2?
We thought 6 millimeter ADO2 is one option. Second option, if I want to use other device, probably muscular VST device of 7 millimeter is ideal in this location. The reason is the inferior part of the septum measures, the thickness of the septum is more than 4 millimeter. So putting a membranous device, I think it is going to be lot of compression on the ventricular septum. So our experience, we use muscular device in case of membranoseptal membranomuscular junction VST, or alternatively we will form an AV loop and then you can use the ADO1, that is a duct occluder first generation. But I think this is a 6.5 millimeter defect, reasonably looking fairly straightforward. So we thought we'll select the case for the ADO2 deployment using a retrograde technique.
So what size are you taking, ADO2?
We have available sizes from 3 to 6, 3, 4, 5, 6 with 2 lengths, that is 4 and 6 lengths. Since the septum at that particular position is 4 millimeter, 6-4 device should be okay here. It should be appropriate.
And you have ensured that it is well away from the aortic valve?
Yes. Yes. So you can show Sudeep, that is what the VST is there.
So it's well away from the aortic valve, isn't it? So it's unlikely to, so you're going to take 6 into 6 now?
6 into 4 we take, our experience shows 6 into 6 at the membranoseptal location will actually eject into LVOT. So I think 6 into 4 should be okay. The ADO2 has got a central vist which is connected by a narrow stem of device to the retention skirts on the either side. So even if you have the septal length a little bit more, there is a possibility that device can stretch rather than the compressive effect on the septum. So 6-4 should be okay in this location unless you have a true muscular VST, either mid-muscular or apical muscular.
I have another question to you, Nagesh. Are you going to change your decision based on angiographic views, or are you just going ahead with echocardiographic imaging only?
Yeah, most of the times we take the decision based on the echocardiogram, but as you said that sometimes multiple defects which often we miss by echocardiogram because of the color jets which will cause confusion, and different planes we may not be able to profile in the same view. So angiographically sometimes if you have multiple jets which will confuse the issue, and if the estimation of the VST by echocardiogram underestimated, often if there is a septal aneurysm which is a little bit floppy and moves, those situations probably angiogram is going to be definitely helpful.
For those of you who are not familiar with the history of perimembranous devices, it has gone through quite a turbulent period. Initially, we started with what is known as an asymmetrical device, wherein the whole problem in perimembranous device is its proximity to the aortic valve and the chance that it might impinge on the conduction system. The asymmetrical device had become unpopular. There are many centers which have given up doing asymmetrical VSD devices because it is estimated that 5% of cases would develop complete heart block. And the worrying aspect of this whole thing is that patients develop complete heart block 2 or 3 years later, and which is completely unpredictable. Then suddenly there has been this excitement. This ADO2 device is actually a duct occluder. It is not prototyped for closing a ventricular septal defect. The difference between ADO2 and the original duct occluder is that it is much more softer nitinol material and it does not contain any fabric. So there is a sudden excitement again to try to close these perimembranous VST with the so-called ADO2. Can you show the ADO2 device to the audience, please?
Show you. The original device is actually 72 wire diameter, whereas ADO2 is 144. That is 50% lesser of what it used to be earlier.
Yeah, can you show it to the audience?
Yeah, we'll show you the angiogram. Yeah, we'll show you the angiogram and then we'll open the device.
There is a feeling that this ADO2, which is a much more softer material, is not going to injure the conduction system. And that is why this enthusiasm for closing perimembranous VSD with the ADO2 device, although it is not recommended at present.
That is one aspect. Second aspect is ADO2 doesn't have any kind of fabric material.
Yes, I just mentioned that. I mean, we have to wait for a long-term results to finally show that this is going to stay, this technology is going to stay for perimembranous VST.
Yes.
Most of us are very comfortable closing muscular VSTs
yes.
because it is away from all the important structures of the heart, the aortic valve, the conduction system. But the controversy is with the perimembranous VST. I think today Nagesh has the largest experience all over the world in closing perimembranous VST devices, VST with the ADO2 device. And of course we all have to wait. The immediate result seems to be very good according to Nagesh's publications. And we of course have to wait for the long-term results. Will it stand the test of time? We have to see that. So Nagesh, can you show us the angiographic report?
Yeah, we'll show the angiogram. We have done in the LAO 45 and 20 cranial, because LAO 60 is going to give little bit of a problem to the working area. So I have to reduce a little bit of LAO and then use the cranial. You can see the VST, which is a little bit away from the aortic valve there. The angiogram is done 25 ml at 12 flow 700 psi. Probably we need to give little bit of high pressure to profile much more.
If you looked at the echo report, the echo pictures, you could very well see that there is a tissue which is separating the VST from the aortic valve. Those things are much better seen on the echo, and clearly this seems to be an appropriate choice because it is well away from the aortic valve. So at least the possibility that this could impinge on the aortic valve is unlikely. And second, we are not sure about the conduction system because that is something which cannot be predicted. Nagesh, I am told that you have just 10 minutes or 12 minutes to go, so can you quickly show us the procedure? I am sure you would be able to do that in 5 minutes. The beauty of this procedure is its simplicity. If you look at the original reports on VSD closure, you have to create an extensive arteriovenous loop to go ahead and approach the VSD in trying to close it. But if you look at this, it's a direct access to the VSD and everything is done through the arterial route. And the whole procedure seems to be quite short as far as the procedure time is concerned.
So we have, this is called as
This
single
6 millimeters is on the LV side, is it?
He said it is 6 millimeter on the LV side. If you look at the device, it's a double disc with the central cylindrical part. Ideally speaking, the central cylindrical part is supposed to sit on the VSD, you know, that tunnel-like VSD which you saw. And that is supposed to sit there. You know, he is supposed to seat it within that.
I just want to show you what we have done. This is a 6 French guiding catheter and we have taken a angulated thermowire here. And then we keep the guiding catheter at the sinotubular junction. We don't cross into LV and then cannulate the VSD. That may injure the ventricular septal defect or conduction system. So we keep there the guiding catheter, flotate the glide wire in the LV, scratch around surrounding the, please go to next slide. So you can see the scene here. We actually pull back the wire into the close to the muscular VSD or membranous VSD, wherever the VSD is there. Then naturally the glide wire will float into right ventricle along with the left right shunt. So you can see that this will take just lesser than a minute time, and once you are comfortable in negotiating the wire, either you can park the wire in the right ventricular apex like in this case, that is because of the jet, or it will go to the pulmonary artery. So once your wire position is okay, then we'll nicely, slowly, gently, we'll negotiate the guide catheter here. You need to give a little bit of clockwise rotation to negotiate the right coronary artery guiding catheter into the right ventricle. So that's where we are. We are here. This is going on live. You can see the picture here. Our catheter is in the right ventricle. The glide wire is still there. We are ready to take the device if you say yes.
Is there any role of PAR procedure TEE here?
Yes. It is most of the time membranous VSTs. You will be in a position to profile the VST by transthoracic echocardiogram itself, unless you have any right coronary cusp or non-coronary cusp prolapse is there.
Nagesha Rao, we request you to proceed with the procedure.
Yeah,
we are left with only 5 minutes.
Then probably
we can have
we
discussion.
need to do the TE.
Continue later.
So we are going to show you the device. You can see the ADO2 device here.
You have to really focus on that because it's a tiny little thing. And can you tell the camera person to focus on this?
Can you see the device here?
Yeah, it's a bit hazy. If you can focus better.
Can you come close to me?
Yeah, it's better now.
Yes, that's better. Can you stretch it?
I am stretching it. It has got 2 reshunt discs. The central waist measures 4 millimeter length, whereas diameter is 6 millimeter. Either side of the central waist you have LV disc and RV disc is supposed to be PA disc and aortic disc, which measures 12 millimeter for the 6 millimeter device.
This this maximum size of the ADO device available at this point of time is for 6?
6 millimeter.
Yeah.
6 into 6.
So
yeah, that's what. Suppose if it requires say 8 mm or 8 millimeter, it's not available.
You can't do it.
So you
only
can
6. Suppose if this
the
VSD
cable
supposed to
for this
require
is a different
10
cable.
millimeter device,
We have a different cable.
Not with this device.
then you can't do a retrograde for a muscular VSD device, right?
Yes.
Then it has to be arteriovenous loop.
Yes.
No, you can do retrograde muscular VST with the larger devices, but you need to use the larger sheaths. We do a retrograde technique using the PDA sheath. That is, if you have a small baby, the problem is the larger sheaths you have to use through the artery. Hence, probably it is not recommended. We have to wait for the bigger devices of ADO2 to come into market.
This device also comes with its own delivery system. They have a special catheter as well as the wire. If you look at the wire for this device, it is very different from the wire for a PDA or an ASD. Can you show us the cable, please? It's very thin and it is extremely long. I think it is about 200 centimeters long.
Yeah, this is what the cable here. Can you show this cable, please?
It's completely different from the usual
this
AST
cable
or a
is very
VST
flexible.
PDA device.
It can take any amount of tortuosity. So I'm loading the device into the sheath here. Flush it.
So he is not using the company delivery system. I think that is to save the cost of the whole procedure. It comes with a multi-purpose catheter and also of course the wire and the loading system, the loader which comes with it. So the difference between this and the other devices is he's just using a guiding catheter. He's not putting a sheath across the ventricular septal defect. He's just used a guiding catheter and taking the device into the guiding catheter and then releasing it. So that actually shortens the procedure and we are able to do it quickly.
System here and the device is already in. You'll be seeing the device in. You can see the device which is coming into the catheter there.
Can you focus on the fluoroscopy, please?
Fluoroscopy, please.
So the catheter tip is in the RV.
So what we do is we'll do an echocardiogram here to make sure that you are above the moderator band.
These are end hole catheters, so you have to ensure that it is a free flow.
So show the echo picture.
Some of us would use a so-called buddy wire through this thing in order that it doesn't get kinked. Because there is because being a tortuous course, there is a tendency for this catheter to get kinked as it enters the RV.
Particularly this Cook sheath are quite sturdy, right? Yeah, Cook's sheath.
Yeah. These are all the so-called Indian innovations. Ideally, one should have used the delivery system provided, but then it cuts the cost.
So this is basically a arterial retrograde technique for closure of VST, a retrograde technique. Otherwise, normally we take an arteriovenous loop and it's a cumbersome procedure. So retrograde, even the same, by retrogradely you can close even RSOV.
Yes.
Some of those RSOVs can be closed very fast, using this device.
So our RV disc is very close to the membranous septal aneurysm over there.
So this process, are you using only echo or are you using a combination of echo and fluoro?
I use a combination of the echo as well as the fluoroscopy here.
Okay.
You can see the RV disc is nicely over there. Can you please apply color over there?
So he has released the distal disc and he's pulling it back into the aneurysm.
So can you take out your hand? So at this point it's important that I'll slowly release the central waist as well as I won't pull the sheath at this particular point. If you pull the sheath, what will happen? The device will be across the aortic valve.
Yes.
So just show the echo now.
Can you do a cine, Nagesh, because your fluoroscopy images are very poor. So there it is, you can see the central disc and you can also see the proximal disc which is on the LV side. And the central disc is supposed to seat on the tunnel-like VST which you saw on the echo.
I'm just readjusting the position. Okay. All right, Sudeep, just go ahead for the echo. Color it, give me contrast.
Are you going to release it now?
No, I'll just perform a check angiogram here through the side arm of the sheath. How about TR? Okay, just remove your hand.
Your fluoro pictures are very hazy.
Just go to...
Can you show this on a brief cine?
17 mag.
Dr. Naishwarao, can you do a brief cine?
So I'm going to do anyway an angiogram here.
Have you released the device?
No, I have not released the device. I'm just checking the position of the device.
These cables are so thin that you can actually do an angiography through the sheath. And that is what he is doing now. Just a check angio here. A hand injection.
So I think we are going to release once we confirm
Even
by
echocardiographically, they are well seated. The disc on either side of the septum.
You can show the echocardiogram, please. Yeah, you can see the echocardiogram. The device either side. Can you see, Dr. Radhakrishna?
Yes, we can see. The echo pictures are much better than the fluoro images.
Yeah. So it looks that the shunt is abolished. There is some aortic regurgitation you can see. That is very important to understand. It is a catheter-related aortic regurgitation. If you have a very less retroaortic rim, it is going to be problematic to assess. So it's better to document that before you release that and make sure that the cable-related aortic regurgitation versus it is actually entrapment of the aortic valve.
Nagesh, can you zoom on to that echo image?
Yeah, echo, please zoom it.
Yes, now you can see that better.
Increase the brightness.
You can see that the LV disc is very well confirmed to the septum, and the central portion of it is sitting across the VST.
So I'm going to do an angiogram here again. So there is some tricuspid regurgitation. Remove your hand.
Is that an LVRA or a tricuspid?
That is LV to RA shunt.
Yeah, it was present before also.
Yeah, usually R series we have seen, you can see the angiogram here, very nicely positioned device, both the sides, LV, RV and central waist. I think if you do an echocardiogram, we are ready to deploy the device. Are you guys happy with the echo? You can see the inferior part of the septum. The device is nicely positioned either side of the septum. There is a little bit of intra-device shunt, and the tricuspid regurgitation, once we release the device, probably disappears. So I am going to deploy the device.
At this point, it is very important to look at the ECG just to make note whether there is any conduction abnormalities on the ECG.
Come and deploy. So we are deploying the device. Yeah, it is already
fluoro,
deployed.
please. Can we see the fluoro? I think. Can we do a cine?
So the device is already deployed. You can see either side, nicely positioned. It's optional to do a LV angiogram followed by the procedure. Generally, we spend a lot of time on echocardiogram rather than the angiocardiograph. You can see here the echocardiogram, the TR actually has come down.
Thank you, Nagesh. You made it look so easy.
Thank you, Nageshwara, for the excellent demonstration.